Well, good morning. I'd like to thank the Institute of Medicine and all of the other organizations that are sponsoring this forum that will, I think, set the agenda in the future for global investments in early childhood. And it's hard for me to think of anything more important than this work. I'd also like to thank the members of the forum for inviting me to speak about this idea of developmental potential as it relates to developmental disabilities. Now, historically, within the field of, within the different spheres of early child development and developmental disabilities internationally, it's as if these two areas have operated in parallel, and there's no integration. My sense from the early child development work that goes on internationally is that they don't want to include children with disabilities. It's more about optimizing the development of children who don't have disabilities. And I've gone around the world trying to understand this position, and one of the explanations I've been given in some countries is that they have very limited resources to invest in child development, and they don't want to waste it on children who don't have a possibility of achieving optimal development. That's been one explanation. Another is just there's a sort of an attitude, I think, within the early child development community that children with disabilities are kind of a lost cause. There's not that much you can do. And the reality is that I think this couldn't be farther from the truth, and that there's actually a lot of things that can be done to prevent developmental disabilities and to optimize the functioning and the participation in society of children with disabilities. So that's one of the points that I would like to make. I think there are a couple of other reasons why we need to include developmental disabilities within this field of early child development. And one of these is just in terms of the prevalence. What we're seeing is that as societies advance and economic development proceeds, the prevalence of disabilities in children doesn't decline. It actually seems, from the evidence to date, to increase. And so we ignore this at our peril, I think, and we won't make good progress in early child development without including a focus on disability. The other reason is just simply in terms of the recent developments in human rights, the Convention on the Rights of the Child and the Convention on the Rights of People with Disabilities both insist that work in whether it's educational or health, we can't proceed without also addressing the needs of people with disabilities. And so it's become a human rights issue, and that's another motivation, another reason why I think it needs to be considered in this context. First, to define what we mean by developmental disabilities, a common definition, also referred to as child disability, is that these are functional limitations that manifest in infancy or childhood as a result of impairments to the developing nervous system or to other bodily systems. And they can affect learning and cognition, mobility, hearing, vision, communication, and behavior. Now, another way to kind of conceptualize developmental disabilities and how that relates to early child development is thinking of these two sort of normal distributions. Most of the tests that are used to monitor early child development will have sort of be normally distributed, the results will be normally distributed, like it's shown here in pink. And these tests typically are developed by removing any children from the population who have known disabilities, and then come up with a normal curve like this. And then disability within that context is usually defined as more than 2 standard deviations below the mean, and it's about 2% of children will fall in that category. For example, if you had a measure of social responsiveness, for example, which is used in diagnosing children with autism, it might be normally distributed like this, with some people scoring below less than 2 standard deviations. Or it could be a measure of intellectual development, IQ, and then children scoring below 70 would be classified as having an intellectual disability. And then children with disabilities are kind of a whole other distribution, as shown on here. And some of them overlap in terms and would be above the cutoff for disability on a particular thing. But they are nonetheless a significant portion of the population. And in reality, there is only one distribution in the population, and it includes people with disabilities. And I think that efforts to improve child development overall are not going to be successful if they don't address the needs of children in the green distribution here as well, those with known disabilities. Another way to think about developmental disabilities that I think is very much unifies it with child development in general, in preparing the disease control priorities volume several years ago, the version 2, we did a chapter on learning and developmental disabilities. And for that work, we, I don't know if I can point on here, but this was the scheme we used to kind of identify on the right hand of this graph is risk factors that begin, and very similar to what Dr. Georgiev was discussing, at the top are factors that affect brain development between the time of conception and throughout gestation and early life. And these are various risk factors that can affect brain development and child development. And then going down on from the top to the bottom goes throughout childhood other kinds of risk factors that can affect early child development. And then on the left hand of the graph are interventions, many of which have been proven to be effective, beginning in preconception period up through early development, folic acid supplementation, things like that, that we have an evidence base for their effectiveness in either primary prevention of developmental disabilities or improving the outcomes for children with disabilities. So and what we use this scheme then to go on and try to evaluate the cost effectiveness of various interventions and what can be done. And I point this out just because I think the same risk factors for developmental disability are risk factors for less than optimal early child development. It really is one field, and the interventions are pretty similar as well. I wanted to talk a little bit about the relationship between childhood survival and the prevalence of disability. This slide just shows the progress that had been made as of 2011. It's the latest data that I was able to get on this Millennium Development Goal number 4, which is to reduce by 2/3 the under 5 mortality globally. And you can see that there's been tremendous progress worldwide. I don't know that we're going to achieve the goal by next year globally or in low and middle income countries, but we've made huge progress. Nobody can deny that. But the thing that I wanted to bring up is that there's evidence, we had hypothesized this earlier, but there's growing evidence that when you have reductions in child mortality, you're going to see increases in the prevalence of disability. And part of this is because children who are at the highest risk for mortality are also at risk for disability. And if they're surviving at greater numbers, it's going to add to the prevalence of disability in the population. In Bangladesh, where the country that has seen some of the greatest declines in child mortality in recent decades, they've also been monitoring the prevalence of disability. We did the first survey there in 1987, and it kind of parallels the times here shown for the reductions in child mortality, and I think this is some emerging evidence of what was predicted, which is that the prevalence of disability will increase with improvements in child survival. And I wanted to point out that this whole concept that with improvements in economic development, we don't see a reduction in the prevalence of disability. We actually see increases. These are data from the United States, which shows the prevalence, what was considered the prevalence of child disability back in 1960 and then going up over the decades to 2009. And one of the things that's been shown is that in the 1960s, when disabilities in children was less common than it is today in the United States, most of those disabilities were physical disabilities resulting from things like post-polio, paralysis, cerebral palsy, blindness, deafness. We've made enormous progress against some of those conditions, not all, but Today, the vast majority of developmental disabilities in children are considered mental disabilities or cognitive behavioral conditions like autism, ADHD, intellectual disabilities, and things like that. So there's a huge change in the composition of developmental disabilities during this period where we're seeing an increase in the overall prevalence. And I think there's no reason to think that we wouldn't see a similar pattern in low and middle income countries as we see improvements in child survival. And I bring that up just because if the goal of investing in early child development is to, if we think that it's going to lead to a reduction in disability, we might be disappointed. It's not just reduced prevalence that we might see, but I think we have to expand our goal to think about improving outcomes for people with disabilities. And then we might have more potential for progress. Another point I wanted to make, that it does appear that children in low and middle income countries are at greater risk for disabilities than in high income countries. This is just one type of developmental disability, intellectual disabilities, severe intellectual disabilities. In high income countries, there's been pretty constantly, this prevalence has been, and it's shown in the blue bars here, typically it's been between 3 and 5 per 1,000 children affected. There's a little bit of evidence emerging that the prevalence of intellectual disabilities, severe intellectual disabilities, might be declining in high-income countries recently. But in low and middle-income countries, where the evidence are available, for the most part, in the red bars here, you can see that the prevalence is much higher in low and middle-income countries than in the developed countries. There's been relatively few data, though, from around the world that can really confirm the prevalence of developmental disabilities. And this is partly because the tools aren't available and the trained personnel to do evaluations and make diagnoses are not available for most of the children in the world. Part of this is because of the expense of the tools, and part of it is the lack of training. But the UNICEF has played a lead role in beginning to monitor child disabilities in low and middle income globally. And this is just from a report that was based on the mixed UNICEF surveys published in The Lancet a few years ago. And the basic finding is that the number of children at risk in low and middle income countries is huge. The median across countries, about 24% of children screened positive for developmental disabilities, suggesting that they're at high risk. But there were no resources in the countries available to follow up the screening results with diagnostic assessments. So we don't really know what proportion of these children had disabilities, what types of disabilities, and that sort of thing. And it sort of raises an ethical issue, too, because in public health, we're not supposed to screen for anything unless we have a follow-up plan and that we can provide services for children screening positive. But in low and middle income countries, you have to start somewhere by generating information. Once the data are there, you can then start developing services. And I think that's just where we are right now globally in developmental disabilities. I wanted to just mention that the whole field of disability has grown tremendously in recent decades, and especially the thinking about disability. And a lot of this is embodied in the International Classification of Functioning, especially the children and youth version, where disability is seen not just in terms of sort of impairments, from the one dimension of impairments, of sort of a medical model of disability, but it's been expanded to include a big focus on functioning and participation in society of children with disabilities. And when you take this more expanded view, you then can really appreciate the things that can be done to improve functioning of children with disabilities and their participation in society. Here's another scheme showing the ICF dimensions, where disability is seen as operating on these multiple levels of impairment, activity limitations or functioning, and participation restrictions. And their factors affecting these operate at biological level as well as environmental factors. And one of the importance of separating these out is that you can actually work on each level to both prevent disabilities, the impairments giving rise to disability in the first place, but also prevention in tertiary prevention, we call it in public health, where you can focus on improving the outcomes for children once they have had a disability. I want to talk now just briefly about the work that we did on the disease control priorities volume 3, I think it was, or 2 rather, where we had the section on learning and developmental disabilities, and we were charged with what can we do. And I know that Dr. Butta mentioned in his introduction that, and I was pleased to hear, that there is a growing recognition of the need to include disabilities within the early child development framework, but there's a question of what we should do. And I think that when we look at the evidence for cost-effective interventions, there's just plenty of evidence, and that's what I'm going to show here today, right now, some of these examples. But in order to try to get a handle on this, what we did was we distinguished between primary prevention, secondary prevention, and tertiary prevention, where primary prevention efforts are focused on preventing the impairment, so to speak, preventing the condition that gave rise to the disability in the first place. Secondary prevention is once the condition, it wasn't prevented, but we might be able to prevent it from becoming a disabling condition for the child. It's considered secondary prevention. And then tertiary prevention is recognize that the child does have a disability. It may be lifelong, but what interventions can be put into place to improve the outcomes for the child. And what we did for this, to begin to evaluate the cost effectiveness of interventions, was we cross-classified these primary, secondary, and tertiary intervention ideas. What are the interventions available by, to what extent we have evidence of their effectiveness and cost effectiveness in low-income countries, which is what we were aiming for. And then when we found, a first review of the literature, we found so little evidence. We've expanded it down to include, well, could we find evidence from high-income countries that might be applicable? And then the next sort of level of evidence is that, no, there's no real evidence, but we might be able to estimate it from other data. And then finally at the bottom, no evidence at all, but theoretically we think the potential exists for cost effectiveness. So this is how we set it up. And then we found interventions in the literature that fit into the various boxes, and then conducted our cost effectiveness analysis to then project what could be the benefits from a global perspective. So we looked at, I'm going to show here just the results for 3 of the kinds of interventions that we evaluated. One in the first column was folic acid, fortification of the food supply, or supplementation of women before conception, ideally. And what we found was that it varies a little bit around the world depending on the country because of the difference in cost of an intervention and the prevalence of the condition. But using the sort of DALI approach, which is not what I prefer to use, but that was what we were told we should use, we found that that folic acid fortification of the food supply is highly cost effective. It's $36 per DALI averted. It's right up there with all the interventions that are considered the most cost effective in global health. So looking at this, there was no reason to think that we can't afford to prevent developmental disabilities, at least to invest in these kinds of interventions. We also looked at Down syndrome screening and termination of pregnancies affected by Down syndrome. Similarly, highly cost effective as an intervention. Brings in a lot of other issues, ethical issues, and so far in this country, though we have the availability of this technology, it hasn't shown to be as cost effective as it was planned, partly because not everybody who does it follows through with the intervention, which is termination of pregnancy. And the other issue is just the aging of of maternal births, so that the trend is toward more births to older women, so that even if we have the intervention, there's a higher incidence of Down syndrome births. So this is an intervention that, in countries where it is available, hasn't yet shown to be effective in preventing disabilities. But the last one here, congenital hypothyroid screening for congenital hypothyroidism, also there we did the benefit to cost ratios, highly cost-effective intervention that can easily prevent developmental disabilities in any area of the world that it was implemented. Just going back to the point about the thinking of disability as a human rights, from a human rights perspective, here's a quote from the Convention on the Rights of the Child. A mentally and physically disabled child should enjoy a full and decent life in conditions which assure dignity, and so on. And I think with this in place, nobody can pursue an agenda in early child development without including children with disabilities. I think that's indisputable. And we have a complete paradigm shift in these conventions and in the International Classification of Functioning, where people with disabilities are no longer viewed as objects of charity or just needing medical treatment to rid them of the impairment, but they're seen as human beings with human rights like others, and we have a duty to do what we can to ensure that they are achieving their potential, whatever it is, and participating in society. So just in conclusion, the main points I wanted to stress are that at a population level, child disability is integral to child development and vice versa. We really can't make progress in either area without unifying these and putting them on the same agenda. I think also to point out that children in low and middle income countries are at high risk of disability, in part because the things that we know how to prevent, the effective interventions that are proven and being implemented in high-income countries to prevent developmental disabilities, for the most part, are not being done in low and middle-income countries. And this increases their risk of disability. And it's happening at a time where we have increasing child survival, and the net result is that increases in the prevalence of disability globally. I think that prevention of developmental disabilities should be viewed as a global public health priority, and some of the reasons for this, in order to be a public health priority, a condition has to be fairly common, the impacts have to be severe, and there has to be something that we can do about it. And disability satisfies all three of those, and so that supports my conclusions. I think my time is up. And I just want to say thank you very much for your attention.